Welcome to Chapter 16, Part 2, and you'll see the picture that I've included here gives us a little inkling about what we're going to be talking about, which is blood clotting. To follow up a little bit with last time's lecture, I just want to reiterate some of these points that I did bring up during the red blood cell life cycle and iron cycle. That red blood cells live for about 4 months or 120 days, give or take. What happens when the cells are recognized and destroyed by the splenocytes in the spleen, we recycle the hemoglobin components. That is to say, the amino acids from the globin protein, as well as the organic molecule of heme and even the iron a little bit if possible. So those new amino acids are digested just like we would digest them in the digestive tract, back to amino acids, and they can be incorporated into new proteins all around the body. Some of the iron is recycled and reused into new heme groups. That usually runs through the ferritin pathway through the liver. However, a lot of the iron is actually excreted, some of which is excreted in the urine. Bilirubin and its close cousin metabolites of bilirubin are water soluble, so they will pass through the filtrate system in the kidneys, but the majority is actually excreted as bile. Which is why if you have an issue, let's say with hepatitis or some sort of liver injury where you can't handle the bilirubin as well, we frequently will see a condition called jaundice. It's one of the more common signs that we see in patients that have some sort of low functioning liver disorder. So here's a picture of jaundice for you. We have a couple of identical twins. And what happens is, and this is very common not just with bilirubin, anytime we have an excess of certain biologic molecules, this can even be the orange color that you see in carrots. People who are OCD about eating carrots will actually get orange color in their skin from the beta carotene. Well, if we have an excess of bilirubin, it will begin to deposit in the skin and result as jaundice. And you can even see jaundice in folks with relatively dark skin. This isn't the best photo. It's got tinted to the yellow a little bit. But in any case, you will begin to see bilirubin accumulating in the scleras of the eyes for folks who have slightly dark or significantly darkly pigmented skin. One disorder that I'd like to talk about just a little bit is known collectively as anemia. And this is a disorder where you don't have enough oxygen carrying capacity to meet all metabolic need. You may be able to get by, but you don't have much margin for error, if you know what I mean. And the normal symptoms include fatigue. That is to say, if your metabolic rate goes up, you're going to start feeling tired very, very quickly because you don't have a lot of excess metabolic capacity. Weakness, pale skin, dizziness, lightheadedness, all these things should make sense from an anemia standpoint. Either you don't have the oxygen carrying capacity in the red blood cells or you don't have enough red blood cells. A lot of times anemia is an imbalance between production and loss. Either you're losing more than you're producing or you aren't producing enough. And there are lots of different causes. There are the ones that involve accelerated blood loss. Some are hereditary in situations where you have very, very fragile red blood cells, okay? The red blood cells don't function properly, they don't have enough hemoglobin, versus something that may be acquired like malaria, which is a parasitic infection, or some other type of disease which causes accelerated blood cell loss. Drug use, very, very common, autoimmune reactions. We can also have inappropriate ability to synthesize hemoglobin. The most common is iron deficiency, not enough iron in the diet. Okay, so inadequate dietary iron or things like folic acid or vitamin B12. Part of the reason why folic acid is strongly recommended for people who are pregnant is because folic acid is essential for DNA synthesis. Given that you're synthesizing literally trillions and trillions of red blood cells every day, it's among the most rapidly dividing populations in the body, and the majority of those are red blood cells. It stands to reason that folic acid would affect red blood cells first. It would also affect dividing cells first, and that's why folic acid is the one nutrient that's generally recommended for women who suspect they're pregnant or who have confirmed pregnancy. So we can have accelerated loss, or we can have diminished production, and we can have genetic reasons and we can have acquired reasons. Moving on, getting closer and closer to our clotting section, megakaryocytes are the precursor cells for what are called thrombocytes, platelets. Okay. Platelets are really, really cool in my opinion. Inactivated platelets are inactive, I shouldn't say inactivated, they haven't been turned on and then back off. Inactive platelets, ones that haven't been activated yet, are generally smooth like this, but as they become activated, and this guy looks like he's getting a little bit angry, and this one's definitely angry over here, they form these sort of spiky outer surfaces full of proteins to facilitate enzymatic reactions and signaling. That's partly what platelets do. They become sticky, and they send signals to cause other platelets to become sticky. The rest of this presentation is now going to be dedicated to the process of blood clotting. And we don't really spend enough time understanding the nature of blood clotting, even though it is exceptionally prevalent in our lives and will be prevalent in your patients and the people you care for. Things like purpura. What causes this? Why do we see this? What are the reasons behind a condition like purpura, which is where you have blood leaking into the epidermal layer of the skin? Or just clotting disorders in general. If you have somebody who has a clotting disorder or who is on a blood thinner, how do you treat that versus, say, a normal cut? Understanding risks of bleeding and so forth are going to be important, and understanding clotting is going to be important in order to understand that. Or, like I said, people who are on blood thinners, like for instance warfarin, Coumadin, heparin, LOX, that sort of a thing. Understanding clotting physiology will play a role in drug-drug interactions and in rehabilitation therapy. So let's go through the general steps first, and then we'll get a little more mechanistic as we go. First thing that happens is that we have some sort of damage or injury to the blood vessel, leading to loss of what we call patency. If a vessel is patent, that means that it is intact and allowing for smooth flow of blood. So we have some sort of injury or damage, loss of patency. That loss of patency usually means that there are proteins that now show up in the blood plasma that shouldn't be there, or cells are damaged and are now sending out cytokines. Oftentimes people talk about proteins that are involved in signaling and enzymatic reactions as factors. It's just another name for some sort of signaling active or potentially enzymatically active protein. So these factors that are involved in the response to injury or damage are now activated. One of the first things that'll happen, especially in the smaller vessels, but less and less the larger the vessel you get. They are less and less capable. But if you're in the meta-arterial or precapillary or capillary area, this is very, very prevalent, and that is vasoconstriction. The cytokines secreted by these cells in this region will diffuse and cause capillary sphincters or smooth muscle to constrict, thus reducing the flow and the ambient pressure in that area. So there's less hydrostatic pressure trying to push that blood out of the vessel. The next step, and this is again something that occurs early, or maybe the only thing that occurs, and this is going to be part A in our mechanistic discussion, is that we form a platelet plug. That is to say, platelets get activated, oftentimes by the factors that are going on here. those platelets will get sticky and they will form a small plug, sometimes called a loose platelet plug. If that's enough to restore patency, that's usually all that happens, or very, very little of the next step. But if the plug does not restore patency, you may get a more robust response that fundamentally leads to the polymerization of fibrinogen into fibrin, which then traps red cells, crystallizes, desiccates, and retracts. A much more robust response. But again, most of the time we only get to 4 here, but if that patency is not yet restored, then we'll begin to see spillover into the number 5 step. So again, we're going to see some cytokines, we're going to get vasoconstriction. This is part A in our mechanistic discussion, platelet plug, and then part B is the formation of an actual fibrin clot. This is the same thing that we talked about in the previous slide, only we're going to add some layers of detail now. So we're going to reinforce what we talked about in the previous slide. It all begins with damage or irritation to the wall of the blood vessel, either an outright rupture or some sort of injury that may threaten loss of patency. And the very first thing that's going to happen is over here in terms of vasoconstriction. The cytokines released by the vessel's wall cells will trigger activation of smooth muscle, leading to vasoconstriction in that localized area. If it's more serious, like for instance, maybe we expose a little bit of extra vasal, shall we say, outside of the vascular wall, something that we never see in the blood protein, which is collagen, coupled with that vasoconstriction event, we may activate platelets to the point where we get what we call a loose platelet plug. And we're going to break that out separately. This is going to be part A right here, when we talk about A and B later on. If we have collagen in conjunction with other proteins that should not be present in the blood plasma, these all serve as activating cofactors for not only platelet plug formation, but also the formation of a true clot. The formation of a true clot here requires activation of an enzyme called thrombin. Thrombin is going to convert the precursor, fibrinogen, into fibrin that then polymerizes. So we had A up here in the loose platelet plug, temporary, or if it's sufficient, then we stop there. But if it's not sufficient or we see additional signaling coming in, then we go to the platelet plug. Hopefully the platelet plug will be enough to restore, and we restore patency to that vessel. That's why in truly severe breaks, we often have to have outside intervention in the form of positive pressure on a wound, because these 2 mechanisms, or shall we say 3 mechanisms, are just simply not enough to restore vessel patency. So now let's look at part A. Part A is the initial one, and again, this happens 99% of the time. You break a few capillaries in the vessel, and sometimes it happens accidentally, sometimes it just happens. You're going to get this platelet plug formation, and like I said, when the breaks are super duper small, this is generally what happens to restore patency. Doesn't involve red blood cells hardly at all. It's really just sticky platelets. And so let's work through this. Part 1 is we have exposed either activated platelets, or a lot of time we get a little bit of collagen, a little bit of extra vasal exposure to a protein that shouldn't be there. It causes those platelets to get angry. They get sticky. They start to get spiky. Notice we have some smooth platelets up here and we have some spiky ones down here. They stick to each other and they release platelet factors that will not only activate other platelets, but will also cause them to be attracted to this. They'll get sticky and they'll adhere to it, just like one of those Velcro ball games that you play. Those platelets will then form that plug, and if hemostasis is restored, then we're all done. Now, if it's larger than that, and you see two pathways here, we have this intrinsic pathway, that's collagen, extrinsic is other tissue factors. This is that additional signaling I was talking about a couple of slides earlier. Have faith, we're not going to talk about those. Okay. If we want to talk about hemophilia, we could talk about all these little cleavage proteins and other ones. It's a cleavage cascade, and it's very, very cool. But where we're going to start is in the activation of this guy right here, thrombin. Thrombin is our keystone protein right here, and all these pathways lead to the activation of thrombin. Okay? It's the centerpiece that leads to not only clotting, but establishing and ensuring patency of the vessel. Do you hear that phrase? Establishing, but also ensuring patency of the vessel. And I'll explain why in a couple of minutes. Now let's switch to part B, which is the actual clot formation. The actual clot formation. If loose platelet plug is not sufficient to restore patency, or we have additional signaling in the form of tissue factors, in some cases a little bit of ischemia as well will trigger this. Then we go into the process called part B. Okay, part B, this is the actual forming of a fibrin clot. Okay. So the first thing that I need to tell you about in this figure is that it is slightly inconsistent. I do not know why, but students have historically had issues with this figure. And so I'm going to make a couple of corrections here for you right now that I would like you to draw in. And in fact, you would do yourself a favor if you practiced drawing the steps in this figure. It doesn't have to be exactly like this figure, but you want to understand what's going on based on the symbology in this figure. And so I'm going to improve the consistency of this figure right here and right now. And the first thing I'm going to do is do that. I've made this arrow the same sort of shading as this arrow over here, for better or for worse. But notice that I've also put this little arrow off of plasmin on top of this arrow. This is the larger symbology of this figure. If you have one of these arrows like this guy, or this guy, or this guy, or this guy, or this guy, and they're pointing into one of these arrows or something along those lines, that means that it is facilitating the conversion of something into something else. Like, for instance, thrombin right here with its arrow into this arrow is promoting the conversion of the precursor, fibrinogen, into the polymer called fibrin. The fibrinogen is soluble. It's a soluble protein. When it is cleaved by thrombin, when thrombin is active, it will form polymers, not unlike what we see in sickle cell anemia. But what we're doing, this is outside the cell. I don't want to confuse you too much. Thrombin is promoting the conversion of fibrinogen into fibrin, which then polymerizes. Okay? That's the coagulation side. Those two external pathways have come here, thrombin is turned on, and it begins catalyzing the conversion of fibrinogen into fibrin polymers. And that's your true clot. The platelet plug is not the true clot. The fibrin polymers trapping red blood cells and white blood cells and platelets is the true clot. But this is a positive feedback loop. Thrombin will continue to convert fibrinogen into fibrin unless there is some way of preventing complete occlusion in that blood vessel. We would stack up with fibrin, and that's problematic. We do not want to lose patency. All we want to do is we want to stop losing blood to the extravasal space. And so thrombin not only promotes the conversion of fibrinogen into fibrin, thrombin, so we have that right here, it's converting, making that conversion, the clotting side. But thrombin also will promote the conversion of the precursor, plasminogen. Here's that ogen suffix again. It will promote the conversion of plasminogen into the active enzyme plasmin. And what plasmin will do is break down, so we're converting that plasminogen into plasmin, we're facilitating that, and plasminogen, once it's activated into plasmin, will break down fibrin that it's exposed to. I will try to show you in a subsequent picture what I'm talking about. I normally do this on the board, and I'm going to ad hoc it a little bit right now. But the plasmin is inside the plasma. This fibrin clot is semi-inside the blood plasma. One face is in the inside of the vessel, and the other face is on the outside of the vessel. So plasmin, when it comes into contact with fibrin, will digest it into fibrin fragments, and we call this fibrinolysis. Lysis is the breakdown, fibrinolysis is the breakdown of fibrin. And thrombin will promote this, and other factors will promote this. This is called TPA, which stands for tissue plasminogen activator. Plasminogen is the precursor, and when we activate it, it turns into plasmin, and it will dissolve or start to dissolve the fibrin polymers that it is in contact with. So when those clotting factors are activated and you start converting fibrinogen into fibrin using the thrombin protein, this is sort of the ideal outcome that you want. That you want enough clotting to occur that you restore and sustain patency without having that positive feedback cycle lead to a complete occlusion of the patency of the vessel. Now this is in response to a plaque that's here, but I'm not going to go there. This is the point. If we have uncontrolled thrombin activity that's converting fibrinogen into fibrin, we would end up with loss of patency and therefore loss of perfusion. We don't want that. And so thrombin not only promotes the conversion of fibrin, it also promotes the activation of plasminogen into plasmin. So let's come back to our figure here. And again, I have taken some of the animations out of here. Once thrombin is activated from those signaling pathways, it converts the precursor fibrinogen into a non-soluble fibrin polymer. But thrombin will also promote the activation of plasminogen in order to plasminogen is now turned into plasmin with the help of tissue plasminogen activator. These two things will synergize in order to turn plasmin on, and plasmin will digest any extraneous fibrin polymers and create fibrin fragments. So when we activate the precursor plasminogen, now we have active plasmin, and we'll digest fibrin into fibrin fragments in a process called fibrinolysis. And TPA is actually therapeutic. So we have TPA right here, tissue plasminogen activator. This was the original clot buster that they used for certain types of clot-based strokes. If you can catch somebody at the right time and under the right circumstances, you can give them TPA to help facilitate destroying that clot that has occluded that blood vessel. The problem is if you give TPA at the wrong time, you'll end up with extraneous bleeding. There are other ones out there, antithrombins and prostacyclins, but I'd like you to know what TPA means, tissue plasminogen activator. It works with thrombin to activate plasminogen into plasmin. So anticoagulants, there's a whole field now. TPA, heparin, and some other things will help dissolve coagulations inside the bloodstream to help sustain patency. And there are lots of natural anticoagulants as well as new therapeutic ones as well. So if we have an occluded blood vessel that has a clot in it, we call that a thrombus. It's a blood clot that's adhering to a blood vessel wall. Damaged, undamaged, well, we could argue about that. One way we can limit the extent of this clotting with an anticoagulant is to make the platelets less sticky. So we inhibit the ability of those platelets to get sticky or stay sticky, or we can block the coagulation cascade, thus preventing the activation of thrombin and the formation of fibrin. So things like heparin, antithrombin 3, protein C, or TPA, and so forth are all examples of that. Hemophilia came about, and hemophilia actually helped us discover ways of blocking coagulation because those factors in the early cascade were defective or lacking. So we understood that these things could be inhibited, and so we went after them as druggable targets, and it's been modestly successful. This concludes part 2 of chapter 16. Thank you for your time, and we will now proceed on into chapter 17 and pulmonary physiology. Thanks.